As I show the spotters, it's just a review of the disk images that we have been projecting so far. Anybody can move on to the mic and tell me what the spotter could be. So what could this be? If nobody says, I'll just carry on, proceed. Yeah, this is a disc coloboma with a retinochoroidal coloboma. When do they develop? They develop when the proximal end of the embryonic fissure fails to close completely, and systemic associations could include CNS malformation, cysts, and chromosomal abnormality. And here, this is a very rare one. You see an optic disc pit with a retinochoroidal coloboma. So pits normally needn't always have associated retinochoroidal colobomas. Now, any of the spotter diagnosis is there, and we've been discussing on and on about a typical wedge nerve fiber layer defect fanning out from the disc margin to the periphery, and how to correlate has been shown by my previous speakers, correlating the inferior defect with a superior arc weight and an inferior RNFL sectoral thinning. So what is this? Like I said, optic disc pit maculopathy. You have a huge CSR with fibrin deposits, and again with a tract up to the macula because of the central serous retinopathy, maculopathy. What is this spotter? This is a disc at risk, and you can see crowding of the optic nerve fibers, and these are discs which can go for non-arteritic type of ischemic optic neuropathy. Small discs which can mimic glaucoma if you have inherent optic nerve head drusens. And look at the way the autofluorescence highlights the multiple drusen on the optic disc. The B scan gives supportive idea with the disc elevation. What about this? Dr. Abhilash talked about bean pot cupping. And so here we have a glaucomatous optic atrophy, and wherein a B scan can show the deep cupping of the optic nerve head. What about these? Do not mix them up with collaterals. You could just be seeing epipapillary loops on the disc. And the typical disc hemorrhage, which if present, though you can have in diabetes, hypertension, but disc hemorrhage at the disc margin is almost always glaucomatous. So you have to think in terms of investigating a normal tension glaucoma. Here, anyone? Collaterals on the disc could be seen in primary open angle glaucoma, could be seen as collaterals elsewhere when you have venovenous collaterals with occlusions, vascular occlusions. This spotter, you have a pale NRR and a large cup. And I said, traumatic optic neuropathy. A clue could be if you have been following up the patient right over the years, the 11 years, having the typical inferior altitudinal defect which has not progressed at all, giving a clue that it is a static optic neuropathy because of the old trauma, and a VP could be conclusive where you can see that the latency is, the amplitudes have reduced, but the latency is almost normal. So here again, it is peripapillary nerve fiber layer edema and an idiopathic intracranial hypertension. Most of our speakers have shown bilateral temporal pallor and associated bitemporal hemianopia. And here we have a cellar supracellular region where the pituitary gland is not seen at all, and you have a stretched optic chiasma. Now here, a 61-year-old lady presenting in 2011 with multiple peripheral neuropathies and with a history of a retrobulbar neuritis just 2 weeks back and fully recovered, and the field's normal, and the left eye which had a recovered old optic neuritis, where again VP could give you hints on the clue. So thank you all for your patient listening, and I hope this instruction course has given you a good insight into optic disc evaluation.